सर ये तो यही कर रहे हैं ना ये लोग, अक्षय और उन्होंने वो कर रखा है, रंजीत मैडम ने मेरी थोड़ी कर दी। पता नहीं, पूछिए वो लोग वहीं पर ही हैं। मैं तो 3:30 से उनके साथ कनेक्टेड हूँ। अच्छा ठीक है। जी जी, मेल कीजिएगा।
हेलो हेलो हेलो, लाइव हो गया? लाइव हो गया, शेयर करो।
दलजीत मैम बताइए।
लाइव
ठीक है, शेयर स्क्रीन।
बैकग्राउंड वो कर दो, ग्रीन क्लियर कर दो।
इसमें नहीं है,
इसमें नहीं होगा, दिस साइड हो जाएगा,
लेकिन वाइट।
ग्रीन स्क्रीन है नहीं ना अपने पास, इसमें है इसके लैपटॉप पे।
छोड़ो।
ठीक है सर, लाइक दिस आल्सो, एंड ये हटा दो।
ठीक है मैम, जो सब क्या हो साउंड
सिखा लो, ये हट गया, इसमें स्क्रीन हट गई।
शेयर।
थर्ड ये था ना।
डिस्कनेक्ट।
Is it audible? Yes, good evening all. So due to the technical issues, we cannot able to start the session soon. Now we have started, right? So after the prelims, NORCET 9.0, hope most of the students who have gone through it, most of the students have cleared prelims. That is a very happy news from NL Academy. Most of the students were cleared. Okay, and regarding the prediction series, whatever we have discussed, lot of questions came. Hope you all know that. For example, if I can say, we have expected burn marshal technique, we have expected McRoberts maneuver, and regarding contraceptions, we have uploaded in the fast track series. Lot of questions were discussed, and it was just like that. Copy pasted questions were there. Hopefully, like we have got some questions related to mains NORCET 9.0. The same pattern of questions we are going to see now. In the NORCET, especially, they are focusing on the nursing aspect, right? Yes, they are focusing on the nursing aspect. You all know that mostly they are focusing on the nursing aspect. Can anyone please acknowledge it? Not clear? Is the question is visible? Yes, yes. Good evening. We are going to start the classroom. Yes. Okay. Okay. You are very eager to watch the session. Yes, I am also very eager to share the questions. So, what special tips I can tell you for the NORCET mains 9.0 is always don't be hurry burry, don't be fast in answering the question. Take time, and you should be predict the question in the particular aspect that which is focusing on nursing. Okay, nursing priority you should choose. So let me discuss lot of points in this MCQ so that you will have the guidance. Okay. An ultrasound is performed, right? The first question in OBG, that is an ultrasound is performed on a client at term gestation who is experiencing moderate vaginal bleeding. The results of the ultrasound indicates that abrupto placenta is present. On the basis of this finding, the nurse would prepare which anticipated prescription. Okay. Delivery of the fetus, strict monitoring of intake output, complete bed rest remaining of the remainder of the pregnancy, weekly monitoring of coagulation schedules until the time of delivery. So which will be the answer? You're telling A? Yes. Delivery of the fetus. Easy questions. Abrupto placentae. Already we have seen this was the scenario asked in the prelims also, but they are focused on magnesium sulfate plus delivery. We will give tocolitis plus delivery or not. That was the question. Okay. Yes. What is abrupto placenta? You all know. We are having two types, that is concealed and revealed type, and both mixed. Always remember what is the most common cause of abruptoplacenta is what? Trauma. Most common complication, that is DIC, disseminated intravascular coagulation. Okay, DIC. Yes. Come on. Now we will discuss some important point. Bleeding plus uterine tenderness is possible. If painless bleeding is there, then it is placenta previa. Which is the most dangerous type? Type 2. Type 2 posterior or anterior? Tell me in the comment box. Yes, type 2 posterior or anterior will be the dangerous, most dangerous type. Okay, yes. First is always stabilize the mother. In abruptoplacenta, first stabilization is must, then prevent for further hemorrhage and quick delivery of the fetus if it is term. Okay, bleeding is significant. This is the important term you should note. Okay, at term gestation, moderate bleeding will be there. Yes, delivery is the treatment of choice. That is the exact thing. If it is less than 37 weeks, 34 weeks less than, then we can wait and watch. If it is more than 34 weeks, always remember delivery. Okay, more than 30 weeks also we can deliver, but always remember 34 weeks is the safest. Yes, type 2 posterior, yes, correct. Type 2 posterior. You are all in the track. Definitely you are going to click. Next question. The nurse delivered vaginally after pregnancy. Okay, vaginally after delivery, complicated by placenta previa. The key term is here. In immediate postpartum period, the nurse notes that the fundus is firm and contracted. Yet the perineal pad is rapidly saturating with bright red blood. Okay, bright red blood, rapidly saturating. Which complication should the nurse suspect and prepare to manage? See, they have given pregnancy complicated by placenta previa in the postpartum period. Okay, the nurse notes the fundus is firm and contracted. Now tell me the answer. What is the keyword here? Postpartum uh, hemorrhage is there, but perineal pad is rapidly saturating, which is the complication the nurse is expecting. Atonicity of the uterus. Are you sure? Genital tract trauma through abnormal placental implantation. Come on, fast, fast. Yes, it is not atonicity of the uterus. If it is atonicity of the they have a keyword called placenta previa. Okay, okay, and there will be profuse bleeding. Profuse bleeding will be there. What is primary and secondary postpartum? Most of the students know, but to clear confusion, I am just telling first 24 hours. First 24 hours, we can say that is primary. Secondary is after 24 hours. Okay. After 24 hours, if any bleeding you are noted, then it is secondary postpartum hemorrhage. Okay. Okay. Now, what is the exact thing here is the placenta implants in the lower uterine segment. Usually, it will be in the upper uterine segment, right? Then an area with less muscular tissue than the fundus. So that abnormality in the placental implantation. So the bleeding has happened. So that's the concept here. Okay. Yes. Voice is not clear. Let me check. Now it is clear. Now it is clear. Yes, clear. Continue. Yes, thank you for your feedback. Okay. Next question. So you train the key differentiating factors. You train atonicity. There will be soft, boggy uterus. Okay, they have given firm. The word called firm. They have given firm uterus. Retained fragments will be boggy, irregular fundus. Fundus is regular. They are given, and delayed hemorrhage will be there. That's what I told. Most common in secondary postpartum hemorrhage (PPH). Okay. What about the coagulopathy? Generalized oozing and bleeding from puncture sites. Okay. Not just vaginal bleeding with firm uterus, it will not be there. Okay. Yes. Next question. Yes. A client in active labor, external fetal monitoring is there. During contractions, the nurse observes abrupt, jagged deceleration in the fetal heart rate. That is very onset, duration, and intensity. Which complication should the nurse most strongly suspect? So mostly we are going to see on nursing aspect. This is how the twist they will keep. You may see in the prelims, the question paper was quite easy to moderate, but they have keep the twist in the options. Which option will be the correct answer? Okay, they will choose the skill whether you are going to be a safe nurse or not. In that situation, how you are going to think. That is the exact thing they noted. So always remember these are the models. This type of questions might be in your mains too. Okay. Yes. Okay, let me check the answer. You all given C, B. Okay. So they have given umbilical cord compression leading to variable deceleration. They have given abrupt, jagged deceleration in fetal heart rate. That is very in onset. Very in onset. This is the called variable deceleration. Other term they may give. Okay. Duration and intensity was also changing. So that umbilical cord compression, variable deceleration. Okay. Yes. So now we are going to see about, definitely there are going to be chances this question might be in your question paper. Okay, please listen carefully. Variable deceleration due to cord compression. Early deceleration, head compression. Accelerations, it's okay. Late deceleration leads to, it is due to placental insufficiency, needs immediate intervention. What intervention you are going to give? O2, positioning. This is the major important thing you should note in wheel chop. Yes. Now these are possible image based question they might ask in your exam. Come on, tell me what is this A image tells what? Then B image tells what? What is this section? What is this section? This is uterine contraction. This is fetal heart rate. Okay. First thing is early deceleration. Yes, you are correct. Early deceleration, ED. Definitely you are going to clear, right? Yes. Good, very good. Velu Murugan, Thunderbolt, Nagaraj, Deep Swipes. Yes. B is late deceleration. Yes, correct. Late deceleration because uterine contraction is there, then sudden drop in the fetal heart rate. Okay, U wave you can see. This is variable deceleration. You all know. Other name they can give. Please find the keyword. Here they have given what? Might be easy. Very in late onset. Okay. Yes. Now, let me go with the tough questions. A client arrives at birthing center in the active labor. After examination, okay, Yes. Yes, network issue only. Now it is visible, I think. 135. Okay. So less pressure on the cervix will be there after amnotomy. The cervix, after amnotomy, there will be more pressure. More pressure will be there. Okay. Decreased number of contractions. There will be increased number of contractions. Okay. Increased efficacy of contractions. Yes, there will be increased efficacy of contractions. Then the need for increased maternal blood pressure monitoring. This is quite, they might be there, but not required after amnotomy itself. Fetal heart rate is very important, right? The need for frequent fetal heart rate monitoring to detect the pressure of prolapse cord. Yes, definitely we are going to have this third one and fifth one. Priority. See, in SATA questions, it is very tricky to answer such type of questions. Okay, in SATA questions, it's very tricky to answer such type of questions. What we are going to do is just pick 2 or 3 options. If it is going correlating, then attend, or else leave the question. Okay, these are very tricky, will make you to marking negative marking too. Okay, please be conscious while attending this question. Okay, yes, that's all I have discussed. So one important point, risk of umbilical cord prolapse, it will increase. So especially when presenting part is -2 station. Okay, -3, -2, -1, 0, +1 station, +2 and +3. Okay, at the level of ischial spine. So baby is here, the fetal head is here. So frequent fetal heart rate monitoring is very essential. Okay, yes. Now coming on to the next question. A client in the labor transported to the delivery room and prepared for cesarean delivery. After the client is transferred to the delivery room table, the nurse should place the patient in which position? Now tell me. This question, fifth question. A mother is on the prepared for the cesarean delivery, not for the normal labor. SPD, spontaneous vaginal delivery, it is not given. It is given cesarean delivery. Client is transferred to the delivery room. What question will give? Okay, yes, you're all right. Supine question with which under the right hip. Okay, no need of any explanation. If it is normal delivery, lithotomy. Only thing they can focus on what? They may focus on position in a different mannerisms. They may give some keywords. Okay, yes. So pregnant uterus can compress vena cava and descending aorta. If the position is flat position, then leading to decreased venous return and cardiac output and uterine placental perfusion. Okay, yes. Next question. The nurse is caring for a client in the labor and monitoring the fetal heart rate patterns. The nurse notes the presence of episodic accelerations on electronic fetal heart rate tracing. Which nursing action is most appropriate? They're asking. Which is the most appropriate action? Notify the healthcare provider in the findings, reposition the client and check fetal heart rate. Okay, tracing, take the client's vital signs and tell the client that bed rest is required, conserve oxygen. Document the finding and tell the client the pattern of monitoring indicates fetal well-being. Yes, it is easy question, right? We will answer if this, because now only we have discussed if it is acceleration, okay. Yes, no need of any intervention. Next question. The nurse is admitting a pregnant client in the labor room, attaches the external fetal monitor, electronic fetal monitor, to the client's abdomen. After attachment, the monitor, what is the next nursing action? Now tell me. Yes, assess the baseline fetal heart rate. No need of, after that, what we'll do after fetal heart rate monitoring. After fetal heart rate monitoring, this is the first thing. Second, what we'll do? Second, what we will do? Yes, all are correct. Thunderbolt, deep vibes, Sapna, you're all correct. Yes. Identify the types of acceleration. Which type of rhythm we are facing? Yes, acceleration we will face. First step is fetal heart rate. Okay, the average rate over 10 minutes. That is important point. Okay, please make a note. That is 10 minutes. Also make a changes. Okay, contractions of frequency and intensity when the baseline heart rate is established. Okay. First point is fetal heart rate, second is acceleration, third is assessing the frequency and intensity. And for 10 minutes, that is also important keyword you should note. Okay, yes. Thank you all. Next one, the nurse is assisting a client undergoing induction of labor at 41 weeks. At 41 weeks of gestation. The client contractions are moderate, okay, every 2 to 3 minutes, lasting for 60 seconds, whether it is reactive or reactive. And internal fetal heart rate, that is FSR monitor is in place. The base fetal heart rate is 120 to 122 beats per minute. Past hour. What is the priority nursing action? Now tell me, discontinue So answer, you're all telling that is A, C, D, B. Yes, there is a network issue here. I think hereafter it won't be. So don't go, students. Please be alert here. Okay. Yes. Please don't go. So we are back to the session here. So first they have given undergoing induction of labor. Induction, which what drug will give? So D will not be answer because induction we have started with oxytocin, right? Induction, they have not given the term. Okay, they have not given the term of oxytocin is going, but they have given fetal distress here. You can see fetal distress here, and uterus is hyperstimulated there. Okay, first is always we have to discontinue the oxytocin infusion. This is the keyword you should note. Okay, this is the keyword you should note. See, they have given undergoing induction of labor. Induction, now we are going to be, we are going to start with oxytocin infusion, right? Oxytocin, we are going to start. So first is always stop oxytocin if fetal heart rate is noted. Okay, yes, it is clear now. Surya Chand, Thunderbolt, Barik Sheikh. Okay, other than that, everyone have answered correctly. So it is happy for me, right? Yes. So oxytocin, as I told earlier, uterine hyperstimulation and leading to placental blood flow, decreased placental blood flow and fetal hypoxia will be there. What is the priority nursing action here? We are going to stop the oxytocin infusion immediately. Okay, where it may cause late decelerations and decreased variability is possible there. Okay, next steps. After oxytocin, we have stopped. So what is the next step here? Repositioning the client. Left lateral. Left lateral. Apply oxygen, then IV fluids. Okay, non-oxytocin solution we are going to do. Okay, then only we are going to notify the physician. Next question. The nurse in the labor room is preparing to care of client with hypertonic uterine contractions. Hypertonic uterine contractions. The client is experiencing uncoordinated contractions that are erratic in frequency, duration, and intensity. What is the priority nursing action? So here, after completing this question, we will discuss the previous question once again. Yes, it is clear. You want me to repeat? I will repeat the point, particular points alone, because this you will make mistake. I'm sure whether we have to notify the physician or they will give oxytocin has been stopped. What is the next step? Sometimes they may ask the question too. Okay. Yes. Okay. The nurse in the labor room preparing the client with hypertonic uterine contraction. The client is experiencing uncoordinated contraction, erratic frequency, duration, intensity. What is the priority action next? Again, you are telling D. Yes, it is from NCLEX only. Yes, it is NCLEX only because this time there is chances for NCLEX based questions. Okay. It's an NCLEX based question only. Yes. Yes, Nagaraj, you are all correct. Provide pain relieving measures. So don't read anything new. So they may ask this type of questions. Students are making a lot of mistakes from this only. Okay. Yes. Provide pain because hypertonic uterine contraction, they have told hyperstimulation is there and patient is feeling pain. So first priority is we are going to give for pain only. First priority we are going to give for pain only. Yes. Okay. Then priority intervention, promote rest, pain relief, and offer analgesics. After that, we can give analgesics as per physician order. Relaxation technique we can give, like diversional therapies. This time they may focus on nursing interventions most probably. Yes. Next question. The nurse is reviewing the primary healthcare provider prescription for a client admitted with premature rupture of membranes. The gestational age of the fetus is determined to be 37 weeks. Which prescription would the nurse question? Next question. Come on now, tell me. So here also PROM, premature rupture of membrane is there. Gestational age they have done, it is 37 weeks. Which prescription would the nurse question? Perform vaginal examination every shift? No, we should not do that. Yes, you're all correct. Yes, yes. So here I will tell you 37 weeks PROM is a stage, active stage, latent stage, transition will be the vaginal examination we'll be doing, right? Yes. So you should not confuse in between. Okay. PROM increases ascending infection, that is chorioamnitis. So frequent vaginal examination is done properly. Allow bacterial entry and are contaminated unless absolutely necessary to assess imminent delivery. You should assess. Nosotophobia. Yes. I am facing networkophobia. Whether currently feeling on networkophobia, don't feel about NORCET. So feel free, be confident. You are studied everything, right? They are going to ask whatever you are studied for the past 4 years. Your nursing course, the patient related questions they are going to ask. Direct questions will be there. Definitely you are going to answer. Please be calm and choose the priority options. Don't see here and there. Focus on the 3 hours or 1.5 hours. You should be on focus, on track for the exam, and you should clear. Okay. Yes. Is it clear? Continuous fetal monitoring ensures fetal well-being. Okay. Here they have given which prescription would the nurse question. This is the keyword here. Fetal heart rate monitoring will do. Monitor vital signs we will do. Administer antibiotic will do. But performing vaginal examination we should not do here. Okay. Yes, performing vaginal examination we should not do here. So why I have done this question? Initially, I told you I have not found the keyword. So I have tested you. Which we should not do, which prescription would nurse question? They have given a keyword called here question. You can see the nurse question. Like this terms, you should make priority. Never, least likely. These are some of the terms. Don't think it is a dragging question, which is a very simple question. You all make mistake. So initially what we will do after PROM, we will monitor fetal heart rate. You will click the answer and come. Usually we will do the mistake, right? But they have given what would the nurse question. They have given the keyword here. Okay. What not to do. Yes, like that it is coming. So performing vaginal examination will cause bacterial contamination and chorioamnitis also. So we should not do that. Okay. Yes. You all captured the question. It is from NCLEX, right? So I am not taking anything new. If I am taking new questions, you might feel very low confidence. So I have not studied anything. So these are the probable questions. From this only they are going. These are model. From this only they are going to ask. Okay, like that. I have picked the question. The nurse has created a plan of care in the client experiencing dystocia and includes several nursing action in the plan of care. What is the priority nursing action? Priority nursing action they are asking. Dystocia. So provide comfort measures, monitoring the fetal heart rate, changing the client's positioning, and keeping the significant other informed of progress of labor. So this time you are going to definitely crack the NORCET. Don't worry. Don't worry. You're going to crack. Don't worry. So experiencing client experiencing dystocia and nursing action, the plan of care. Monitoring fetal heart rate. You have done the question, right? Yes. So provide comfortable measures will not make sense here. Here they are asking about priority nursing action. Nursing action, the sense safeguarding the patient. First and foremost is safeguarding do if the fetal heart rate is decreased. Okay, yes, change the positions. Okay, yes, that's what they're telling. Difficult or prolonged labor due to abnormal uterine activity, fetal presentation, or pelvic structure. Okay, yes. Next question. The fetal distress is occurring in the laboring client as the nurse prepares the client for cesarean birth. What is the most important nursing action here? Slow the intravenous infusion flow rate, continue the oxytocin drip if infusing, place the client in high follow position, administer oxygen. So, fetal distress is noted. So, what is the priority action here? Fetal distress is there. What is the important nursing action? Shall I reveal the answer? Yes, you're all right. Fetal distress is there. Late deceleration. Okay, laboring client, late deceleration will be there. So it indicates placental insufficiency, fetal hypoxia. So administer oxytocin via face mask. Okay, yes. Next question. The postpartum nurse is taking vital signs of the client who is delivered healthy newborn 4 hours ago. The nurse knows the client temperature is 100.2. What is the priority nursing action? So what is the difference between prelims and mains? We will discuss. Okay. These are some prediction points I will give. Okay. Vital signs is there. So what you are going to do? Document the findings. 100.2 is normal. C. Suman, C. D. Yes, you are correct. So it is purely from NCLEX based questions. So these are, see, 50% will answer correctly because we are going through the NCLEX. But the thing is, between prelims and mains, this direct question will not be there. Direct question will not be there. If you understand the concept, you will definitely answer the question. They might keep some twist. Direct question will not be there. They will match the, they will rearrange the distractors or change the distractors. They will change the options pattern. Everything can be changed, but this pattern will be there. What the pattern? Postpartum nurse. Okay, vital signs you are going to check, and there is a temperature increases there. So within 4 hours, okay, healthy newborn, the mother is having 100.2. What we are going to do? Priority action. So it indicates hydration. Okay, the slight temperature elevation during the first 24 hours postpartum is normal, often due to dehydration and exertion. See, first 24 hours, if the temperature is increasing, it is does not indicate an infection. It is a normal process. Always we have to encourage the mother to have fluids and promote hydration. If it is more than 100.4, Okay, then we are going to inform to physician. Okay, then we are going to notify if it is more than 100.4. Okay, now it is clear. Yes, there are questions they will ask. What about our prediction series? Our prediction series, it came around 5 questions. What we have discussed. Okay, 5 to 6, I think 7 questions came direct questions. It was there. Okay, yes, correct. When performing a postpartum assessment on a client, next question, the nurse notes the presence of clots in the lochia. The nurse examines the clot and notifies that there are more than 1 centimeter, larger than 1 centimeter. Which nursing action is most appropriate? They're asking. Come on, fast. See, people who have studied NCLEX, Mosby's, PR Yadav, any book, any type of platforms you have studied, you are going to answer. Mostly students are facing confusions in most of the concepts. So for that only, I am giving some important clues to them. Those who studied, those who know everything, no need of any guidance. Okay, they will clear as it is. I am talking about students who need some special guidance. Sir, most of the students are telling after the exam, sir, I am having confusion. Okay. After seeing the question myself, I have felt it's confusing question. So that's how the competition is, right? They want to filter people. They want to pick up bestness. So you should be best in preparation, right? Yes. Nurse notes clots 1 centimeter. Okay, this is the changes of PPH. If it is more than 1 centimeter, it indicates what? Bleeding, lochia. So notifying obstetrician will be the answer. Easy question, right? Yes. Now we are going to see some important concept, that is, I predict that this question will be in your this from this lochia. There are chances. Lochia, rubra, serosa, alba. If it is a foul smelling, then it indicates infection. Okay. If it is a foul smelling, they have given lochia foul smelling, then it indicates what? Infection. Birth to day 3 up to day 4, we can say it is rubra. Serosa, it is an yellowish color, that is pinkish brown, watery. Okay, sorry. Lochia serosa is pinkish brown color. Alba, it is yellowish white. Pinkish brown, yellowish white, creamy consistency. And it is serosanguinous. Bright red, you all know that. Lochia serosa is day 4. From day 4 till day 10 may extend up to day 14. Keyword, keyword, keyword. And day 11 to, that is 4 to 6 weeks. 6 weeks of postpartum we can expect, that is Lochia alba. Okay, yes. Some clinical notes, less than 1 centimeter is a normal and gradually decrease fold order if it is an infection suspicion. Mostly occur in Lochia serosa. Infection stage occurs in this stage only. Lochia serosa. Some important thing you should note in this Lochia. Okay, quick recap we have done. Now tell me, next question. The postpartum nurse is assessing a client who delivered a healthy infant by cesarean section for signs and symptoms of superficial, that is venous thrombosis. Which sign would the nurse note if superficial venous thrombosis are present? Now tell me here. Paleness of the cuff area, coolness of the cuff area, enlarged ardent veins, palpable dorsalis pedis pulses. Yes, hypovolemic shock. The mother will go for hypovolemic shock. So there will be hypoventilation or hyperventilation. Tachycardia will be there. Hypotension will be there. Okay. DVT. They are asked about deep vein thrombosis. No, they have asked about superficial venous thrombosis where present. If it is a superficial venous thrombosis, there won't be any paleness, there won't be any coolness, but there will be enlarged, hardened veins will be there because this superficial venous thrombosis they have asked. They have asked about you are suspecting a patient after cesarean section. You are observing that there is superficial venous thrombosis. What is the nature of thrombosis? They are asking. What will be the nature? Superficial venous thrombosis. What will be the nature? While inspection, what you are going to assess? It is an enlarged, hardened veins. Veins are enlarged. Simple question. Okay. Don't be confused with you. Okay. Superficial venous thrombosis. It is an inflammation signs, localized redness, tenderness, swelling, warmth, and palpable hardened veins. Simple. Okay. Then this comes. Okay. Paleness and coolness will come in arterial compromise, not venous thrombosis. Atrial ulcers. Okay. Yes. Oh my God. Okay. Yes. I am also praying to the God network should be not stuck in between. Okay, because the session is going good, you're all answering good. Okay, sometimes there will be you the question which you predict will not be there, so don't do the thing because 10% negative marking is good. 10% negative marking will happen. Definitely it is going to happen. Whoever we are going to give, there are chances. Whoever will burst, they will predict and they will leave the question. But as of now, you should be under control that which question I am going to answer, which question I am going to leave. That you should be clear. Okay. Yes. Next question. The nurse is assessing the client in the fourth stage of labor. Notes that fundus is firm, bleeding is excessive. What the initial nursing action? Now, stage 1, 2, 3. Now you are all going to answer. B, B, C, C, D, D. See, they have given a term, bleeding is excessive. What is the point in massaging the fundus? What is the point in massaging the fundus? Okay, bleeding is excessive in the sense, it indicates primary PPH. So we have to notify the physician, and after the physician order, we are going to do the interventions here. Okay, come on now, tell me latent phase, active phase, and transition phase. Now tell me 1 to 3 centimeter, 4 to I think 4 to 7 centimeter, then 8 to 10 centimeter. Stage 2, 8 cardinal movements will be there till delivery of baby or placenta. Okay, then delivery of placenta here. Stage 4, observation. From the delivery of placenta to observation. Okay, these are some important points. Yes, yes. This word will do mistake. Okay, please be conscious while attending the MCQs. It indicates uterine atonicity. Okay. Now tell me, the nurse is preparing to care for 4 assigned clients. 4 assigned clients. The client at most risk for hemorrhage. Which client is more prone to have this hemorrhage? Prime Paris client who delivered 4 hours ago, delivered 6 hours ago, after oxytocin induction. Multifarious woman who delivered, and primiparious client who delivered 6 hours ago and had epidural anesthesia. Now tell me. Yes, it is easy. So don't confuse with epidural anesthesia and oxytocin induction. Oxytocin induction indicates hemorrhage, uterine atonicity is possible. Hyperstimulation of the uterus is also possible. Okay, because multifarious large baby oxytocin induction, which indicates postpartum hemorrhage. Okay, yes. Next question. The client is monitoring postpartum client who delivered 1 hour ago, received epidural anesthesia for delivery for the presence of bulbal hematoma. Which assessment finding would indicate presence of hematoma? See, vulval hematoma. What are the clinical changes? Pain will be there. Then the abnormal pain, intensive pain will be there. Now tell me, again C, B. So what is pain here? Now tell me what is pain here? So they have asked after 1 hour of delivery, epidural anesthesia they have given, presence of vulval hematoma suspicion is there. Which assessment finding? Assessment. So if pain is not there, how we are going to assess? First is always vital signs. Vital signs plus pain intensity. Vital signs plus pain intensity we are going to stage. Okay, any changes in the vital signs, like because bleeding will be there, right? So hypovolemic shock. Hypovolemic shock. Tachycardia, hypotension will be there. So for that, we have to assess vital signs first. Then we are going to assess for heavy bruising, intense pain. Any changes is there, any bleeding symptoms, which indicates symptoms. This signs, changes in the vital signs. Okay. See, heavy bruising, they have given presence of vulval hematoma. If there are any change in the vital signs, that is the first assessment finding. Heavy bruising, we are going to assess anything. We are inspecting. Assessment in the sense we are going to do what? Heart rate, but first we will be checking the pulse, blood pressure. Then we are fifth vital signs is pain. Pain intensity also we are going to see. Okay. Yes. Heavy bruising will not be there. Signs of heavy bruising will be seen in vital signs. Signs of heavy bruising will be seen in vital signs. How we are going to see the heavy bruising? Visible inspection, bleeding. Before that, we have to assess vital signs. Heavy bruising, if you are seeing, then you are not a safe nurse here. Before, if you are seeing heavy bruising, before that, first we have to assess vital signs. Okay, consider not a delivery patient. Okay, we are considering an emergency situation here. A patient with pelvic injury comes to the casualty. What is the priority intervention you are going to do? First, you will be assessing the pulse rate. Okay, first assessing the pulse rate, secure IV line. Okay, cardiac monitor, everything you will connect. Whether you will be assessing amount of bleeding here there in that emergency situation. No, we are not going to assess any bleeding there. First is always resuscitation. First is always vital signs. Vitals is the first answer. Okay. Yes. Now, vulval hematoma management. Lot of confusion you are going to see. So, first inspect the vulva, swelling, discoloration, firmness. If vulval hematoma is suspected, then go for assessment. Assess pain level. Pain is vital signs. Nothing but vital signs. Then monitor tachycardia, hypotension, internal bleeding. Okay, this is the important point you should note. What is the C option here? Complaints of intense pain. Here, subjective data will not work because 1 hour ago the patient got epidural anesthesia. The patient cannot able to say the amount of pain. Intensity of the pain cannot be told by the mother, right? Yes, it is class 1, class 2 or class 4. Class of hemorrhage. Okay, then initial nursing interest, very important point. Provide analgesics and side lying position, intake output chart monitoring, you all know. Then size and stability, this all you all know. Okay, then incision and drainage is very important in clots if expanding. homeostasis to be maintained, drains may be placed. And post-procedure care, vital signs and lochia. See, first and foremost nursing care is monitor vital signs and lochia. First is vital signs, then go for another thing. And what is the important management here? Provide warm cyst bath after 24 hours to aid healing. After 24 hours, this is important point. Okay, stool softeners, because the patient should not stain. Should not stain. It indicates bleeding. Okay, perineal hygiene, signs of infection, you all know that. Next question. After normal vaginal delivery of healthy fetus, that is controlled contraction was done to help remove the placenta from the uterus. Gross examination of the placenta is similar to the image given below. What is the true regarding the placenta in the image given? Yes, vasoconstriction, correct. B. Yes, it is easy question. So quick recap, maternal surface, they will give a keyword basal plate, fetal surface, chorionic plate. Okay, it is rough, dull, dark red in color. Okay, uterine wall, umbilical cord is attached to the fetal surface. Easily you can identify fetal surface, shiny part. Keyword they have given, bluish purple. Divided into cotyledons, 21 to 22 cotyledons will be there. Some book says 18 to 20 cotyledons also. Okay, it helps anchor the placenta to uterus, takes part in gaseous and nutritional exchange. Okay, these are some important points. Yes, hopefully you have not seen the answer. A prima gravida came to the regular antenatal care in the first trimester. Okay, she has no complaints of dysuria or increased frequency, but her urine routine reveals 10 to, that is greater than 10 to the power of 5, that is E. coli count. Her urine culture was done again and showed same organism. What is the most common complication of this condition? You have seen the answer, right? You have seen. Yes. In the first trimester, preterm labor is more possibility. Yes, preterm labor is more possible because E. coli infection is there. Asymptomatic bacteriuria in pregnancy. Okay, important term. This might be your question. Like this question, they might be asking you. Okay. Yes. Next question. Now tell me the answer. Identify the grip shown in the image. This might be a question. This might be a question. Yes. So you all know about which will be the first, second, third, and fourth. Now tell me. First is frontal grip. Second one is lateral grip. Third one is Pavlik grip. Fourth one is pelvic grip. Right? Yes. So now which step is this? This lateral. Easy question, right? Easy. Yes, correct. What if they were asked abdominal examination for pregnant women? Abdominal examination. If the word comes, first is inspection, second is auscultation, then comes palpation. In this palpation, we are going to apply this Leopard's maneuver. Okay. Always remember for abdominal examination, if they ask inspection, auscultation, palpation, and percussion, they might focus on this thing. Okay. Yes. So these all about this. This is the fundal grip. First thing they have shown in the fundal grip, assess the fetal flank region. Fundal palpation we are going to do. What if a smooth curvature in the lateral grip if we are facing? Then the baby is facing what? Baby's head is left side if you are facing the curvature. The baby's head is in the right side. Okay. Yes. Whether in the third grip, whether we are having ballotment or not. Ballotment. Ballotable or not. Here, convergent or divergent. It is engaged or not. Okay. Yes. No, it is not recorded. It's a live class. Yes. The nurse is teaching, next question, the nurse is teaching the clients to determine the time of ovulation by taking the basal temperature. What change is expected to occur in basal temperature during ovulation? Yes, for abdominal examination in pregnant women. In pregnant women, if they ask, then we will do palpation. No percussion will be there, sorry. Yeah, sorry, it is no percussion will be there. Only palpation we are going to do there. Okay, that is called Leopard's maneuver. If they ask any confusing question, they may focus. Okay. Yes. Slide drop and then rises. Okay. Yes. Slide drop, then rises. Time of ovulation. First, day 1 till day 28. Mid cycle is day 14. Pre-ovulatory, that is pre-follicular phase, post-follicular phase, that is we will say secretory phase, ovulatory phase. Here, proliferation, pre-ovulatory or proliferative phase, which is the major, both as positive and negative feedback, estrogen. Positive and negative feedback. FSH and LH responsible and inhibin B. Okay, these are hormones, important hormone, please, which plays a vital role here. Luteal phase will be here from here. Mid luteal phase, if they ask, that is day 22. Mid luteal phase is day 22. Okay, that's all about this. So around the time of ovulation, the basal body temperature shows slight dip, that is 0.2 to 0.3 degrees Celsius, followed by sustained rise will be there of 0.4 to 8 degrees Celsius due to thermogenic effect of progesterone. Which produces progesterone here? Which structure produces progesterone? Come on, you all know that, right? This, I will say, corpus luteum. Okay, yes, correct. Next question. A client at 10 weeks of gestation elects to have induced labor, induced abortion. After receiving oral mifepristone, she returns to the clinic 2 days later to have misoprostol inserted vaginally. For when should the nurse schedule a follow-up visit? Okay. Now tell me, mifepristone dosage, misoprostol dosage, at which day we are going to give dosage and which day we are going to give. Yes, it is 4 to 8 days. We are going to do that. Yes. A standard regimen, medical abortion with mifepristone, And misoprostol includes follow-up within 1 week, typically 4 to 8 days to confirm. Okay, complete expulsion of products of consumption, absence of retained tissue or complication, monitoring bleeding, pain, and emotional well-being. Yes, correct. I think it is 300 mg, 200 to 300 mg. It is 500 mg. Yes. It is 800. Yes, correct. You all know. Next question. A primigravida in the labor has achieved full cervical dilatation. The nurse explains the presenting part is now descending towards the pelvic floor, but the woman has not yet started active bearing down efforts. This phase of second stage of labor is called. This phase of second stage of labor is called. Full cervical dilatation is one keyword. Okay, the nurse explains now descending towards the pelvic floor, but the woman has not started active bearing down efforts. See, full cervical dilatation, if it is attained, then it indicates what is latent phase. How you are telling C? See, it is stage 2 labor, second stage of labor. Whether it is propulsive or expulsive. See, the bearing down, active bearing down effects will has not started. Then it is propulsive phase. If it is an expulsive phase, bearing down reflex will be started. Okay, no latent phase. See, latent phase is what? Latent phase, active phase, transition phase. Latent phase is 1 to 3 centimeter. It is 4 to 7 centimeter. It is 8 to 10 centimeter. How they have given full cervical dilatation? It is more than 10 centimeter. Then how we can say that is latent phase? Active phase also will not be there. Active phase insert 7 centimeter. Right? Yes. I am not, as I am fast or slow. So I need you people to understand this concept. This is how the question paper will be. As per the prediction, not direct questions will come. This type of question will come. They will analyze your critical thinking. Don't ever without reading or gently reading one time the question. Don't go for the answer. Have a quick recap of the question again. Understand what they are asking. Always try to repeat or reread the last line of the question, what they are going to ask. Already they have given second stage of labor, so you didn't see the keyword here. Then how you will be telling that latent phase and active phase? See, in this I will tell a clue that you can see in this four options which is directly related. This first option is 100% correct, right? This is first place, first 100% correct. Expulsive phase also 80% correct and 80% related to the concept. This latent phase and active phase not at all related. Latent phase, active phase is quite related 50%. This is only 10 to 20% related. This is how they will formulate the distractors. Okay, this is how they will going to formulate the distractors. You are going to capture the correct answer, 100% correct answers. Okay, yes. So not known is not your problem. Now we have known, now we have read it or not. That is the concept here. Now we will analyze what is propulsive phase and expulsive phase. So in propulsive phase, as the question suggests, that full dilatation and ends with presenting part which is the pelvic floor. Before bearing down. After bearing down is expulsive phase. They are talking about second stage of labor, where the cardinal movements, 8 cardinal movements are going to take place. That is maternal bearing down begins, where the baby is trying to come out. Yes, the labor starts. Yes, next. All you have understood the question, the answers, everything is clear. We will go on to the next. Yes, Propulsive and expulsive is the second stage of labor. Indirectly, they are asking. Okay. Yes. Next question. A 22-year-old primigravida group, that is blood group of O negative, presents with incomplete abortion at 14 weeks of gestation. Uterine evacuation is planned according to ACOG guidelines. What is the most appropriate dose of anti-D immunoglobulin to be administered to prevent isoimmunization? Okay, mother's blood group is O. Incomplete abortion at 14 weeks of gestation. As per ACOG guidelines, if it is less than 12 weeks, greater than 12 weeks, less than 12 weeks, we can say that is B is the answer. No, no, no. 300, Mike, that is 1500 international units as per ACOG guidelines. Okay, if it is less than 12 weeks, then we can reduce the dose. Okay, yes. 50 microgram we are going to give if it is what? Less than 12 weeks of any other abortion, MTP, anything. Okay, yes. It is clear. Next question. A 22-year-old woman, primigravida, delivers vaginally at primary health center where oxytocin is not available. The provider decided to expected management on third stage of labor. After delivery of the baby, what is the next step expected management protocol? Expectant management. Okay, they are telling about active management of third stage of labor. That we are having expectant management. We will discuss that after delivery. Next question is A. Perform controlled contraction immediately after birth. Immediately after birth, advanced, that is active management of the labor, telling that what it suggests to us. Oh my God. Methyl ergometrin, we will give IM route. No, will not give. Now I will come with your route. Perform control contraction immediately will not do. Immediately will not do. So I am going to neglect A option also. Either it will be B or D. Now tell me. A, B, D. Yes. Now you're all options of phobia. Yes, options of phobia, you're all there. Or confusionophobia. Yes. So we have to wait and watch. So oxytocin is not available. The stage of labor is over. Then after delivery of the baby, then expected management is signs of placental separations. You have to note. Wait for signs of placental separation. Okay. First principle in expected management, observe natural separation. No controlled contraction, everything should not be done. Okay. Yes. So manual removal immediately only if indicated. Placenta fails after 30 minutes. Excessive bleeding, not a first step. Important thing, please make a note. Manual removal immediately, not to do only after 30 minutes if fails. Okay. Yes. Next, another question. A 27-year-old multifarious woman delivers at a prime tertiary hospital. The team follows active management of third stage of labor. Oxytocin 10 units IM was given 1 minute of delivery. After waiting for uterine contraction, controlled contraction was applied twice but failed. What is the next step? Come on, tell me what is the next step here? Repeat controlled contraction after 2 to 3 minutes. Wait for spontaneous expulsion of placenta. Proceed to immediate manual removal of placenta. Administer broad spectrum IV antibiotic prophylactically. 2 times it is failed. Now tell me which will be the answer. So yeah, it is seen that okay, never ever try to answer this type of question. If you are having less confidence, then leave the question. Less confidence in the sense I'm not telling that you are sure. If you're not sure, if your mind tells it is not sure, then try to leave the question. Okay, here what they have done. See, 1 minute of delivery they are given. After waiting for uterine contraction, controlled contraction applied twice but failed. What is the next step? Practically, you just think 2 times you are doing controlled contraction. Then again you are going to try, right? Again we are going to try. After it is fails, then within 30 minutes we are having, right? 30 minutes we are having. After 1 minute controlled contractions you have given. So after 2 minutes, 2 to 3 minutes, you are going to repeat. Okay. Yes. So what for this standard active management of third stage of labor? If placenta doesn't separate after first attempt, repeat 2 to 3 minutes again. Okay, correct expected management, but not in active management of third stage of labor. Correct only if immediate manual removal 10 to 15 minutes after failure. Okay, after failure of 10 to 15 minutes, then immediate manual removal we can do. Okay, yes, broad spectrum and here they have given 2 to 3 minutes. First, immediately after delivery, if it is fails, they have given 30 minutes. Okay, don't confuse between this. Next question. A 25-year-old woman delivers vaginally. The hospital follows active management of third stage of labor, but she develops hypertension during labor. Hypertension during labor. Which uterotonic agent is contraindicated for use in the third stage of management of labor? Don't see the answer and answer precisely now. Hypertension is there, which drug will be giving? Contraindicated, they are asking, sorry, contraindicated. B, yes, it's correct. Methyl ergometrin should be avoided for hypertension where it worsens the hypertension. Okay, contraindicated preeclampsia. Safest drug uterotonic oxytocin. That is misoprostol also used if oxytocin is not available, not contraindicated in hypertension. Carbiprost in asthma, not hypertension, especially to prevent PPH, carbiprost is used. Okay, yes. Now we are going to see the active management of third stage of labor in a quick recap. Here we are having, so after third stage of labor, we are having expected management and active management. Here, delivery of the baby is done. So after delivery, we are going to start neonatal resuscitation, right? Neonatal care we are going to start. Clamp, divide, ligate the cord. First point in expected management. Wait and watch. I have told wait and watch for placental separation. Then catheterize the bladder, guard the fundus, wait for spontaneous separation of placenta. Okay, if placenta is separated, wait for spontaneous expulsion with the aid of gravity. Natural process is expected management. This is naturally occurring process. If fails, assisted expulsion we are going to do. Then again it fails, injection oxytocin and methogen 0.2 mg IM we are going to give. This is simple process. Okay, then again we are going to examine placenta, inspect vagina and perineum. Simple. Okay, this is expected management. Coming on to the active management, here we are going to give some interventions. What injection oxytocin 10 units IM we are going to give. Methogen we have given initially to the mother within 1 minute of delivery of the baby. That is active management here. Again, clamp, divide and ligate the cord, same procedure. Here comes the point: to deliver the placenta by controlled contraction after the delivery of the baby, availing first uterine contraction. After delivery, when the first contraction is done, then we are going to give this controlled contraction. If it fails, what? Repeat after 2 to 3 minutes. Then again it fails, then wait for 10 minutes, repeat the procedure. Then again it fails, manual removal we are going to do. So this is the key point where you are going to do mistakes. Important MCQ point. Fails, what we are going to do. Again it fails, what we are going to do. They will combine this four thing and they will ask for this option. Fan voice is disturbing. Yes, let me give me a minute. Now I think it is fine, right? Yes, this is the important point you should note. You should note in this active management. Okay, simple points I will repeat once again. Expected management is naturally occurring. Naturally we are going to give time and delivery of the baby. After the delivery of the baby, placenta is going to deliver, and inspection and vaginal inspection also we are going to do, and inspect the placenta. Active management in the sense we are going to do intervention where oxytocin with methogen we are going to give immediately after delivery, that is 1 minute of delivery. Clamp, divide and ligate the cord and deliver the placenta with controlled contraction smooth after the delivery. If it is fails, then repeat the controlled contraction. Again, if it is fails, wait for 10 minutes, repeat the procedure. Then again also if it is fails, then manual removal we are going to do. Okay, here inspect the vulva and examine. Again, we are going to give slow IV infusion of oxytocin or methotrexate. Okay, it is clear? Yes. Thank you. Thank you. Yes. Now tell me, what is the procedure? Identify the procedure here. Now tell me this, what is this procedure is? This clear? C, obstetric conjugate. A, AC, 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 C. C is the answer. I want more answers. Yes. All have answered? Everybody have answered? Yes. It is artificial rupture of membranes. Okay. Yes. It is artificial rupture of membrane. Amni. Okay. Yes. Don't confuse with obstetric conjugate. Okay. This might be confusing question. Okay. Like this, the questions they can ask. Now tell me, what is the rate of hemoglobin rise expected with oral iron therapy after third week of treatment? After third week of treatment. No, no, no. It's going. Yes, now tell me. A, B, C, D. Sajita, Pooja, Kumari, Nirmala, Mary. Come on, tell. B. Okay. So it is 0.7 grams per deciliter per week. So that is the exact thing. The expected rise is 0.7 gram per deciliter per week. They are asking after third week of oral iron therapy. Third week they are asking. Okay, per week if we identify, then we can identify the third week of treatment. Okay. Yes. Next question. Come on, degree of TAS. There is more chances to ask question. A 25-year-old primigravida delivers a full-term baby vaginally. On perineal examination, the nurse notes the laceration extending to the vaginal mucosa and perineal muscles with intact and sphincter. The patient complains of moderate pain and mild bleeding. Based on the finding, what is the degree of perineal tear in this patient? What is the degree of perineal tear? Intact anal sphincter they have given. Yes, if it is involved with anal splinter, then we can consider third degree tear. So it is easy, right? Second degree tear. It is second degree tear. Here, according to RCOG guidelines, which is very important, you should note injury to the perineal skin only first degree. Second degree injury to the perineum involving the perineal body muscle but not involving the anal splinter. Here you can see intact anal splinter. Coming on to the third degree, injury to the perineum involving the anal splinter complex, both external and internal. Both external and internal splinter complex, they are involved. Here we are having three classification, 3A, 3B and 3C, where less than 50% of external anal splinter thickness thron will be there. More than 50% external anal splinter thron, that is thickness thron will be there. Both EAS and IAS thron will be there. Internal and external will be there, that is 3C. Fourth degree involving the anal sphincter complex and anal epithelium. Okay, involving the anal epithelium. First degree, second degree, and third degree, fourth degree. In third degree, we are having three categories, that is 3A, 3B, and 3C. Okay, it is clear. Identify the contraceptive device. Easily you can answer. Is clear? The image is clear? Okay. This time they may focus on they last time they're given Malay and Maladi, Chaya, that and all. From contraception, if they focus, they may give this copper T questions. Okay. So always remember what is this? Yes, it is copper 380A. Most of them have answered correct. Now tell me which will be the answer. Identify the given instruments. Sorry, this is I cannot convey it in English because both the audience are there. In Hindi, I cannot able to explain because both the audience from all over India they are watching. So medium will be like English so that everyone can easily understand, right? Yes. Killard forceps. So then what is this instrument? Yes, it is Killard forceps. It is Killard forceps. This is Piper's forceps. Where there will be a division. In between division, these are look-alike. These are look-alike instruments. Most probably there are chances. So I have put this question. Let us see if the question comes in the exam or not. Okay. Yes. Let me see this question. Okay. Next question. A 55-year-old post-menopausal woman presents with bulging sensation in the vagina, urinary incontinence when coughing, and difficulty with bowel movements. On examination, the nurse notes protrusion of the anterior vaginal wall. Protrusion of anterior vaginal wall. They have given the keyword and descent of posterior vaginal wall, but the uterine fundus remain at normal position. What most likely the condition? The cystocele, rectocele, uterine prolapse, stress fracture of the pelvic bone. Now tell me. Come on. CA. Yes. Here it is uterine prolapse, right? Protrusion of anterior vaginal wall. Now, here comes the table. Okay. Yes. Anterior vaginal wall they have given. Which will be the answer? Question not clear. See, here they have given bulging sensation in the vagina, urinary incontinence. Urinary incontinence they have given. See, when coughing, difficulty with bowel movements. On examination, the nurse notes protrusion of the anterior vaginal wall and descent of the posterior vaginal wall, but the uterus fundus remains normal position. Okay, then how you will say that is uterine prolapse? If it is prolapse, patient is having uterine incontinence. So the answer will be cystocele. Prolapse of the anterior vaginal wall associated with urinary incontinence. Okay, aligns with patient's primary urinary complaints. Okay, zoom the question, sir. So you can pass and you can see, right? You can pass and you can see the question. So question is clear. Try to answer priority. Okay, cystocele is between the bladder and the vagina. Rectocele, rectum and the vagina. And enterocele is, you can see in the enterocele, prolapse of small intestine into the vaginal canal. Uterine prolapse is descent of the uterus into the outside vaginal canal. Outside the vaginal canal, it is protruding. Then it is totally different. Okay. Yes. That is enterocele. This is uterine prolapse. Yes, it is clear. Yes. Coming on to the pelvic floor prolapse, what is the condition tells pelvic organs, or that is bladder, rectum, uterus, intestine, descend into or outside the vaginal canal due to weakness in the pelvic floor muscles and connective tissue. Here we are having cystocele, rectocele, enterocele, and uterine prolapse. I have discussed this. Okay. The last question of this section. A woman has excessive uterine contraction without relaxation and fetal distress. Which drug should be given first? Which drug we are going to give first? Oxytocin, terbutaline, misoprostol, methylergometrin should be given first. They are asking. Now tell me which will be the answer. B. Yes. Terbutaline should be given. The patient with hyperstimulation, excessive contraction without adequate relaxation, fetal distress, it indicates. Okay. Goal to improve fetal oxygenation. Okay. Yes. Oxytocin, hyperstimulation, there is possibility. Misoprostol also induces contraction, contraindicated here. Oxytocin will worsen the situation here. Uterine contraction will be increased. Uterine contraction are high, then terbutaline will be the drug of choice. Okay. So that's all about this prediction series. We have come to the end of the session. So whatever you have studied, you just revise it and go. So I will tell you some important tips and tricks to crack the NORCET mains. Always remember, if you are assessing some questions related to OBG, child health nursing, segregate the question. Segregate the question and answer. In OBG, what are the topics you can read, that is from obstetrics, from OBG, gynecology we are having separately. So first in this, anatomy structures. I will write some IEL topics. I will write. You just go through and go through this. Like instruments, all instruments you can read. In this, anti, that is minor ailments. Minor ailments. High risk pregnancy like GDM, eclampsia, these are IEL topics. Labor, all labor, and screening. First trimester, second trimester, third trimester screening, like physiological changes too. Physiological changes during pregnancy, that presumptive, probable, and positive signs. Clinical based questions they may ask. Okay, all image based questions related to Leopard's maneuver, they can ask, and these are some IEL topics which you can focus. Okay, any doubts regarding this, you can ask me so that I will clarify you now. Okay, or else we will wind up the session. Okay, always remember, section wise you can divide section A, section B. We are having 4 sections, right? Section C and section D. First, second, and third, and fourth. Remember, 20/25. That is the criteria you should keep. 20/25 is 20 minutes for 100% known question. 25 is for 50 to 80% known question. In the first section, up to 45 questions, in that you know only 40 questions, sorry, 40 questions you know, 20 questions you know 100%, then you can attempt, you can leave other 10 questions, 20 questions, because if it is the first section. First section might be tough, so leave question maximum there. Try to attend B, C, and D because that section might be easy for you. Okay, yes. Any doubts you can ask, or else we will wind up the session today. Okay. Yes. That's all for this session. All the very best. All the very best for your mains. Okay. All the best. Thank you all.